trained people on the other side of the conference. Rohit Arora is next. Dr. Arora is the chairman of program at Chicago Medical School. He's a professor of cardiology, professor of physiology, professor of biophysics. He's a very prolific writer. He has published more than 400 papers. He just finished a book, and he is currently in Chicago. We're trying to lean on him to move westwards and maybe come to Los Angeles. People with his talent should not be left in the Midwest. Rohit.
Thank you very much. You know, the temptation is great. When I left Chicago this morning, it was 35 degrees, so you can imagine, I saw the sun here in sunny Bakersfield with a little bit of fog. It's rolled in from LA. Some people call it the smog. So there's great temptation to be here. And I wanted to congratulate and thanks Dr. Bambi for putting up this marvelous program. It's great to be here, also with Dr. Singh, Surabjit Singh. He was one of our ex-fellows, and the great team who have built this first program. A show of hands for Dr. Bambi for doing this incredible job. So, Dr. Bambi mentioned that I'm from the Midwest, so obviously if you look at the content of all the speakers, all of them illustrious speakers and experts in their field nationally, they are all speaking about device therapy. So Dr. Bambi chose me, poor old me coming from Midwest, to talk about medical therapy, which is my application in atrial fibrillation, and essentially talking about anticoagulation and stroke prevention. So I wanted to start off with this slide, which Mike showed earlier, and basically to make the case, this is where our concern is. This is data from the Olmsted County Mayo Clinic. As you see on the vertical scale, that the vast number of patients projected to be about 2.53 million in the United States tend to be above the age of 75 and 85. The last patient I saw in my hospital Friday evening was Hattie. She was 87, and I want you to think about this patient. She had an unprotected left main stent. She was in dual therapy with aspirin and clopidogrel. She had paroxysmal AFib. She has hypertension. She has heart failure, and she's very bright, active, and she also had a TIA before. And she is on multiple medications. Her creatinine clearance of creatinine is about 1.2. So the issue becomes, what to do with Hattie, and whether we should give triple therapy with dual anticoagulant and anticoagulation, because most of our patients fall in the older subgroup to talk about. So one thing what we have learned over time, these are some important studies here, that in addition to stroke, the incidence of which goes up order of magnitude 2 to 4% in non-valvular AFib, which is what we're discussing tonight, the mortality independent of getting a stroke also goes up about 2 folds. And that is belied by the fact, as Mike suggested, that AFib does not exist in isolation by itself. It portends structural heart disease or organic cellular heart disease to follow. So speaking of anticoagulants, the drug of choice, which also came out from Wisconsin, the Midwest incidentally, was warfarin for a very long time from University of Warfarin, and University of Wisconsin, and that's where warfarin came out. They have the patent on that. So Coumadin or warfarin has been a wonderful drug. It was approved in 1954, and we have used it, and we use it in about 50 to 60% of the patient, despite the advent of newer anticoagulants, which is what we're going to talk about. But there are many limitations, as you see, in why it is falling off favor. So that led to the search of the newer anticoagulants. So I'm going to focus on the 3 which have been approved by the United States FDA. Dabigatran, which is the first direct thrombin inhibitor, followed by 2 of the direct factor Xa inhibitors, evaroxaban and apixaban, and in the fold coming up into existence, edovoxaban and etrixaban. And then in the phase 1 and phase 2 trial bases are the newer vitamin K antagonists, and of course, if all else fails, mechanical occlusion therapy, which you'll hear about, is the drug therapy of choice in those conditions. So once you have a patient with AFib, how do you risk stratify their issue of stroke? So all of you know this, like a mantra, the CHAD2 classification is what we have used in time immemorial since 2001, work done by Gregory Little and colleagues from England, we now deploy the newer classification, as you saw in ACC-AHA, which came out in April of this year, now deploy the CHAD2 VAS2 classification. So some of the quick differences, so all of us know heart failure, Hattie had that, she had hypertension, she was 87, she did not have diabetes, but she did have stroke, which gives you 2 points. So she was a very high-risk patient, so she has 5 in the score of a maximum 6, as you see on your right of the panel. The more the risk factors, the higher the chance of stroke. If you have 5 risk factors, the risk of stroke goes up, order of magnitude in 1 year, about 12 to 15%. And then if you look at the division of the score, and I'll tell you why this came about, and this is what the recommendations currently suggest that we should be using, is the CHAD2 VAS2 classification. So in addition to the traditional risk factors, 3 more risk factors were added to this equation. That is, if you had any vascular disease, or that is, we all have those patients who are between 65 to 75, and we toss and turn about treating them. And then that is the sex category, more effectively the gender, not how many times you have sex. The female gender is attributed to be another point. So in totality, going back to the CHAD2 VAS classification, is a maximum score of 9. And the current recommendations only use CHAD2 VAS2. The Europeans still use the CHAD classification. So if you have a score by this classification more than 2, then you must anticoagulate these patients. When you have CHAD2 0, you need not anticoagulate them. And when you have CHAD1, then it's a toss-up and between an antiplatelet versus an anticoagulation. So that is the discrimination. Why CHAD2 VAS came about? Because in these guidelines, the older guidelines, CHAD classification suggested anticoagulating these patients when you had CHAD scores of more than 2. But 1 became the toss-up again. So if you do insist on using this score, the older score, then the only issue comes when you have CHAD1. To give an aspirin or an anticoagulant, how do you separate? In that case, you still come to the CHAD2 VAS2 classification, and then if you get CHAD2 VAS2 2, and you anticoagulate 1, if you decide you can anticoagulate or give an antiplatelet. This is the comparison in range adjusted, and the quantum of risk goes beyond with the additional risk factors, as you see, by comparison to the CHAD classification. So the CHAD2 VAS2, it enunciates risk at a higher score in the higher risk factors, as you see here in these patients. Now, we discussed the risk stratification. What we also use in Hattie is, if we did decide to anticoagulate her, we also have to look at her bleeding risk. And this is the equation that we use, a common classification. Many of you may know about this, the Has-Bled classification, which is hypertension, abnormal renal or liver functions, stroke, bleeding, labile INR, if you can control it, or the time to TTR, or the time to therapeutic control of INR, is less than 60%, elderly age, and in the intake of other drugs which may interact, or with alcohol. So if you have a maximum score of 9, that's the highest risk. If you have a score more than 3, you are at a higher risk for bleeding in this category. So this is a very good paper to use or read, and this is a great algorithm, as you see. In our risk category, most of our elderly patients with the risk will fall in this. They have a higher risk, as Abby had it. They also have a higher risk of bleeding. Our sweet spot is this, and that this is the brown area where the risk is higher and the bleeding risk is low. So this becomes an easy decision in stratification of risk, as opposed to the difficult spot in what is the best proposition is here when the risk for bleeding and the risk for stroke is the highest in this patient. So this is a time immemorial meta-analysis by Robert Afton colleagues. As you see in many of these trials, the 4 or 5 largest randomized controlled trials, which were done with Coumadin over time, and I have to admit, I've been an investigator for all of these since the 80s. And if you see how effective or how powerful warfarin and Coumadin is, if you see the risk reduction, if you see the relative risk reduction in the end, order of magnitude by intention to treat analysis is order of magnitude 63%. Very, very powerful drug. If you look on treatment, it is about 83%. I can't recall a drug over the last 35, 40 years which has been so powerful in risk reduction. If you look at any cardiovascular drug, as far as reducing the incidence of fatal and non-fatal stroke in these patients. But the challenges with warfarin are many. All of us know these: delayed onset and offset of action. How do you reverse? That can take time and days. A narrow therapeutic index, we have to keep it between 2 to 3. Numerous drug-to-drug interaction and drug-to-disease interaction. A lot of these interactions lead to this drug being the dream drug for lawyers, at least from New York, where we worked for the last 25 years. And then how unpredictable is the dose. So some patients require 2 milligrams to maintain the INR between 2 to 3, others require 10 milligrams. So that is the biological variation and challenges, both genetic and phenotypical with warfarin that transpire. And this is the classical graph that we learned from, and Elizabeth Heilig pioneered this, and this is a study by Doug Singer and colleagues. It shows the sweet spot. This is why the INR came about, that if you have the INR between 2 to 3, that is our ideal goal. It's very hard to keep them in that. About 45 to 50% can be maintained. And that's the major limitation of warfarin, as you see. If you go below 2, your risk of stroke goes up. If you go above, particularly 4.5, the risk of intracerebral or bleeding in the brain goes up. So that is the challenge, and that is why the NOACS, so the newer emerging anticoagulants, came to the fore. So in classical distribution, what has been approved is the direct factor Xa inhibitors, as we talked about the Vigatrend, which is a direct thrombin inhibitor. 2 of these have been approved as far as the factor Xa inhibitors. So what are the current indications? So I am just focusing on non-valvular AFib, but as you know, all of these 3 NOACs have other indications with venous thrombosis, and now almost all 3 have similar approval processes. The rivaroxaban is most extensive as far as venous antithrombotic incidence is concerned, but all of them obviously came to the fore. The first kid on the block was the Vigatrend in the RELY study, and then the Rocket, the rivaroxaban was approved in 2011, and sequentially apixaban in 2012. These are some of the pharmacokinetic differences, so I won't belabor that. I just want you to focus here in the half-life. If you look at the half-life, it's about 11 to 12 hours throughout. And how is that this drug, rivaroxaban, is approved to be given once a day? These 2 guys, the Vigatrend and the apixaban, are given twice a day. And this is not therefore based on the half-life. The studies were done twice a day, and these folks did their study based on the phase 2 trials where they thought once a day would be satisfactory, and that's how they got the approval, which is an important contribution, because if you have a drug twice a day versus once a day, obviously it is more compliant in those patients. The other fact I want you to focus on, and one of the limitations of the NOACs, is the potential for renal excretion. If you see the Vigatrend, about 80% very sensitive as far as renal function, which we didn't appreciate till we finished the RELY study, and that's why there was trouble as far as the post-marketing bleeding incidences with the Vigatrend. As you may have seen, the TV ad, the bad drug. And then rivaroxaban had this much lower, 1/3, 36% excretion from the kidney, in opposition to that, apixaban had 27%, even less. And that is why the adjustment to renal function is proportionally important. And with AbbVie algorithms, anytime you give the NOACs, you got to be very careful of where the renal function. And the last attribute, because of the lower protein binding, this drug can be hemodialyzed better if you came into the situation of massive bleeding in this patient. So the great attribute of the NOACs is that you don't need to do an INR, you don't need to monitor any standards or any therapy, which is hard for us because we're so used to monitoring, we're always looking to monitor, and that is the prime. So the challenge obviously is at the moment we don't have an approved reversible agent, but there are 3 studies which are in the phase of completion. One has been done. It's the murine monoclonal antibody, which I think would be approved by next year in a facilitated approval process by the United States FDA. So the first study, very quickly, was a RELY study done with the Vigatran. This was the large randomized study into 3 components: the Vigatran at a lower dose, 110 BID, and the Vigatran at a higher dose, 150 BID, compared to warfarin. And in all the 3 large trials with all the 3 NOACs, there were 2 primary endpoints: the co-primary endpoint of efficacy and the co-primary endpoint of safety. This was a non-inferiority. Those of us who enjoy statistics, it had a less broad non-inferiority, or the N or Z margin. The limitation of this study, and I will talk about the limitation of all the 3 studies, it was open label, even though it was randomized. The IRBs, obviously, the standard was comparing warfarin, which obviously had to be kept open label to monitor the INR in those patients. So what did this study show as far as efficacy is concerned? As you notice here, clearly superior in the 150 BID, statistically superior to warfarin, and at 110 dose it was non-inferior as far as efficacy is concerned. The bleeding risk, clearly much more bleeding at 150 BID. Blue, that was 1% higher GI bleeding, but the bleeding risk at 110 BID was equal to that of warfarin. So the United States FDA drug panel had a conundrum, and that is which dose to approve. One was better as far as superiority with efficacy, with more bleeding. In their infinite wisdom, they approved the 150 BID dose, and they took that 1% excessive risk of GI bleeding in these patients. So this is a summarization. After the bleeding episodes came out in New Zealand and Japan, and primarily related to the renal dysfunction, the FDA did a post-marketing survey of all the known literature and the databases, and they did not find a high risk of bleeding in their post-marketing surveillance. The next NOAC, which came about in 2011, was rivaroxaban, also linked to creatinine function and related to creatinine clearance. Does not obviously again require routine monitoring. This was their largest randomized study, the Rocket AFib study. There was a direct comparison, warfarin versus rivaroxaban at 20 milligrams daily versus an INR of 2.3, again, co-primary efficacy and safety. This study, if you really enjoy the statistics, very difficult to read. A lot of controversy when it was first approved. There were 2 non-inferiority endpoints and 1 superiority endpoint. And if you follow the efficacy curve, it did meet intention to treat population as far as non-inferiority, and that is how it got the approval, and the bleeding risks were smaller. So the results of the Rocket AFib suggested that you could use rivaroxaban in a non-inferior fashion as opposed to warfarin. And then in 2012, apixaban was approved. And if you notice, the largest study was the Aristotle study in 18,000 such patients. The comparison was with warfarin versus apixaban, same endpoints. And with this drug, they did look for superiority. And if you notice clearly, apixaban at 36 months to follow was superior statistically and a reduction of 21% relative risk reduction in contradistinction to warfarin. And the major bleeding also met superiority, unlike the other two drugs and the other two studies where they met non-inferiority. In addition, cardiovascular mortality was reduced statistically, another incidental endpoint. And then the adjustment to creatinine clearance is the least, as you saw, it was 27% in this. So the other thing to remember when you look at these studies, obviously these are apples and oranges, and you can't compare. One thing that we like to look on is the mean INR for the time 55 to control of that is one of the TDR that the Maven study showed anticoagulation over 60% improved. So the emerging anticoagulation studies, the Aristotle and the Reliance studies showed over 90%. But it is a roxadation in the FROX did show non-inferiority with less bleeding. And Betrixaban is the next one in the Explorer 10A study, which I think has a very bright future. And then come the guidelines. In closing, I'll tell you what I do, and it's purely based on my opinion, which is generally right based on the data. Not that I'm saying that, but the guidelines. So where do you use NOACS? What are the American guidelines? The contemporaneous American guidelines, as I alluded to, came out in April of this year, the ACC, AHA, and the Heart Rhythm Society of America. To remember that the NOACS have an equal class 1 indication. So in non-valvular AFib, you could use all of the above, warfarin, the Vigatran, rivaroxaban, and apixaban. The only difference is the level of evidence, the truth behind it. As you know, now we classify drugs by level of evidence A, B, and C. A is the truth, meaning more than 2 randomized studies, large population-based studies, large use experience. 2 is when you have 1 or more randomized studies and other smaller studies, less use. And 3 is when you have no data to back the drug. So if you notice, the new guidelines have given class 1 indication as far as the NOACs are concerned, but the level of evidence in opposition to warfarin is B in these patients. So that's an important caveat to remember in these patients. And then the Europeans always think differently, and they have given, and there is more of an expert opinion rather than less evidence-based. So they have given NOACs in general, the American guidelines have given a class 2A indication. In general, as far as triple therapy is concerned, in the European guidelines have given a class 1 therapy. So I brought up the issue of Hattie, who needs possibly triple therapy, 2 dual antiplatelets and an anticoagulant, and what would we do with the patient? So the question in closing is, what should we do? I mean, we have so many options. Should it be by whoever visits our office and tells us a good drug? So warfarin, where do I continue using? I continue using in my low-risk patients who are not labile, who have well-controlled INR. And I have to do the INR once a month. And clearly, there's an unassailable position if they have not had an embolic or bleeding episode. 2 is renal dysfunction, end-stage renal disease, and dialysis. And those patients, I love warfarin. The least trouble you will get into as far as the creatinine clearance issues are concerned is warfarin, the most data that we have. Then if you have mild to moderate renal dysfunction, you do have the option of using the NOACs, but I still prefer warfarin. I don't have the time to follow these patients. The creatinine clearance keeps migrating. Hattie, we saw her last creatinine clearance, 4 of them were done every month. And she had different creatines. One time it was 25, another time it was 50, all over the board. She was on diuretics. So unless I can validate and follow them closely with abnormal creatinine clearance, I still prefer warfarin, just because I don't want the headaches of monitoring the creatinine. Then, where do NOACs help? The power of NOACs is they cause less bleeding, yes. Where is the bleeding less? They cause less bleeding in the brain. And most of the efficacy, particularly the superiority with the apixaban got, with reduction in 40% of all 3 drugs in less bleeding in the brain. And there is some investigative data from our neighborhood which suggests why that happens and why people with the NOACs bleed less in the brain. So that's another previous patients with previous DI strokes. That is another line of therapy. The NOACs is what I would use. And then cost considerations, I'm sure you're concerned about that. So cost is an issue. Somebody can afford, obviously, Coumadin is pennies to the cent is in opposition to some of the newer drugs in these patients. And that is how we go about as far as the choosing the best proposition in these patients to follow. So in closing, my message is that obviously the NOACs give us a new horizon of therapy. The choices have become large and vast, and the options keep expanding. The great benefit is with NOACs, you do not have to monitor them, you do not need the INR, and you don't have to worry about lawyers so much, although the bleeding is the equation where it does go up, and so you need to worry about bleeding as a risk concern. So that's kind of the utility of NOACs in our 9 hospitals that we now deploy. We still use about 50 to 60% warfarin in comparison with the NOACs. We selectively target. And between the NOACs, the last message, and this is not promotional, I'm not a speaker for any of those other NOACs, is the statistical data seems to be the best, in my opinion, with the Pixaban, because the superiority, both statistical superiority, both for efficacy and both for safety as well as bleeding, the reduction of mortality, and the least association with renal abnormalities in those patients. So with this, I'd like to end my talk, and thank you very much for your attention. Give me a chance to talk.
Thank you, Rohit. We have exactly 2 minutes for cross-examination. Any questions? Yes, sir.
I'm a surgeon. So if these patients are on this and they will have a major surgery done, so on the note, how should you treat them, or how should you stop them?
This is a great question, and Sumit myself were talking. It also applies to ablation that we talked about. In general, it is the risk-benefit ratio. If they are extremely high risk as far as AFib, we saw the CHAD classification, CHAD2-WAS classification. If in those, then you need to bridge them. The approach with the NOACs in those patients is you generally stop 2 doses before going for surgery, because that is enough to wash out. If there's renal abnormality, then you need about 3 days for 6 to 8 doses to be stopped with the NOACs, because their half-life is much smaller in general. With Coumadin, it's variable till the INR is under 2. And it depends whether the surgery is emergent or non-emergent. And if it's emergent, then you can do the surgery under an INR of 2 in this patient. And then restart the anticoagulation depending on their risk. If they are in high risk classification, then you start it right off surgery. So, for example, in ablation with risk, you now go through with the anticoagulation on board with lower INR, and continue that after the procedure.
Well, thank you.
Beautiful talk, Rohit. Can I ask you about the switch? You know how the risk seems to increase when you switch from Coumadin to NOAC. Can you tell us your advice on how best to do that?
So switching is not a good idea. I'm not a switcher. I'm told on the West Coast there are a lot of switchers. So the risk of bleeding, in addition to the HAZBAT classification, there are other factors: the gender, female gender, older age, obviously, alcohol intake, intra-aortic balloon pump, femoral approach, depending on the procedures that you use. But switching is a risk factor for bleeding, and more so if you use heparin, more so if you use low molecular weight heparin. So we prefer not to. So in the post-hoc analysis, many of these studies, switching is a dangerous proposition, especially in very procedural times. So it's a good strategy just to continue in those. Although if you do, yeah, Coumadin to NOAC. So if once the INR is under 2 in general, you can switch to the lower node if you want to.